Right, so hi guys, we're continuing on the NEET PYQ series. We did part 1, this is part 2. We have done quite a bit of questions in the first half, continuing on the second half. Now, in the continuation series, I have a question. Here we have a male patient who is here, presented with a 0.3 centimeter nodule on the left nasolabial fold that is present, right? It was excised and the pathological examination was done. The image is given below. So what do you think the exact option or what is the image given below looks like, right? Now, if you look at the entire component, look at the squamous epithelium and then it is going and digging deep into it. Now, this is the characteristic of basal cell carcinoma, right? So, in the basal cell carcinoma of the skin, you would see there are basaloid tumors arising from the epidermis. There will be nest of the basaloid cells with the scanty cytoplasm and elongated hyperchromatic nuclei. You will have peripheral palisading, you have the myxoid stroma and the peritumoral clefting is noticed, right? Now, we talk about basal cell carcinomas, important point. Majority of them are, they're slow growing. The risk factor is UV rays, 90% of nodular or nodulocystic. They can be classified into high and low risk. Remember the categorization of the high risk. If it is more than 2 centimeters is in size. If it is greater than 2 centimeters in size, right? Now, remember the name of the surgery that you can do here is what we call it as the Mohs micrographic surgery. It is your Mohs micrographic surgery where you will put on the loops and will try to dissect 1 millimeter of margin per se until you get the margin to be negative, right? The chemo that you can put across here or the chemo regime that you can follow for basal cell carcinoma is your 5-fluorouracil and imiquimod, right? So that the drug that can be used as the agents for the basal cell carcinoma. For the skin malignancies, another important is your malignant melanomas. In the malignant melanomas, you have two classifications that I've shown you here. One is your Clark's level, another one is your Breslow's classification. Both of them have to be looked across. So when you look at the Clark's level, when we say level 1 tumor, the level 1 tumor, it is confined to the epidermis. It is called as in situ variant. Level 2, it is going all the way to the papillary dermis. Level 3, it is not extending beyond the reticular dermis. Level 4, it invades the reticular dermis that is present. Level 5, it goes into the subcutaneous tissue, right? So these are based upon the depth that you have. The Clark's level, Breslow's is based upon the depth, or I can say the involvement of the depth that is present, right? So in the Breslow's, when you look across here, level 1 is less than 0.76 millimeters. From 0.76 to 1.5, level 2, 1.5 to 4 is level 3, and beyond 4 millimeters in thickness invasion, it is called as level 4, right? So all these are conclusive with respect to the skin malignancies. You should know about the basal cell carcinoma. Malignant melanoma is something that you cannot go to the exam without reading. So going to the next question, what do you have as the next question? Let's look through it. We have a 45-year-old patient that is present across. Complain about pain in the one side of the neck. She is afraid of eating food as it worsens the pain. Ultrasound of the salivary gland is done and shown below. What is the most likely diagnosis? So you have a 45-year-old patient, pain in the one side of the neck that is present. She is afraid of eating food because pain increases. Now, what is the condition where the pain increases on eating food? It is going to be your salivary gland pathology. Example is going to be your silolithiasis. So this is a case of silolithiasis. So when you talk about silolithiasis, that is stones, remember 80% of your silolithiasis are going to be radio opaque. Only 20% of them are radiolucent. What is the most, if I say just quickly important points, remember 80% of the silolithiasis are radio opaque. They are radio opaque and 20% of them are radiolucent. 20% of them are radiolucent. If I say what is the most common site, the most common site is your submandibular gland. The most common site is the submandibular gland. Reason, it is rich in calcium, that is submandibular gland secretions. They drain in the anti-gravity direction, reason number 2. And reason number 3, you will notice that the duct of the submandibular gland is compressed by the lingual nerve, so there is stasis, right? So all these 3 reasons attribute for the development of silolithiasis, that is stones in the salivary gland, especially in the submandibular gland. Now, one of the characteristic feature, as the pain worsens on eating, the minute you see this point, you're on for silolithiasis, right? Now, it's a small notes that we have been discussing in our regular classes as well. Remember, whenever we talk about the stone that is in the submandibular gland duct, you need to understand that there is a nerve, that is your lingual nerve, that is going to hook. So the submandibular gland duct, it is going to take a hairpin loop, or it takes a U-turn after, and the sublingual gland that is going to arch it down. Okay. Now, here's an important point. If the stone size is less than 4 millimeters, I will be doing a Dormio basket extraction, that is under UST guidance. More than 4, it is going to be lithotripsy, but that has to be beyond, if it is beyond your lingual nerve. If it is stone is posterior to the nerve that is crossing, then you have to go ahead with submandibular gland excision, right? So if the stone is anterior to the lingual nerve crossing, you can go, if you're not able to remove it by the Dormio basket or with the help of lithotripsy, then you can go with longitudinal incision and the stone extraction can be done. Remember, it has to be closed. That duct has to be closed with a 5-0 absorbable sutures, right? Now, what are the complications associated with the submandibular gland excision? Any surgery, hematoma, wound infection. But here, remember the nerves that can get damaged. Your marginal mandibular nerve, your lingual nerve that is going to arch through the duct, your hypoglossal nerve, and nerve to mylohyoid, that is submental skin anesthesia, can be caused across here. What is the rule of 2 in the submandibular gland? The rule of 2 in the submandibular gland, it consists of 2 capsules. The 2 parts divided by the mylohyoid muscle. There are 2 conditions, that is stones and tumors. The 2 nerves which are closely associated, one is lingual and other is hypoglossal. 2 to 4 centimeters below the mandible is the line of incision that you have to keep. You cannot keep at the mandible or the margin of the mandible, because the marginal mandibular nerve crosses, or it goes through here, and damage can occur if you take along with that line. And 2 times you have to ligate the facial artery, because the slippage of ligature is the most common cause for resultant of post-operative hematoma, which you don't want to see in your patient, right? Chalo. So next question, what do you have? The next question is, I have a delayed intravenous urogram, that is IVP is there. What is the most likely diagnosis? You can see it is all mashed up, and this is what the classical appearance of the putty kidney is going to look like. So how does the PUJ obstruction or the staghorn calculi or the cystic kidney look like? This is a characteristic of staghorn calculi. Now, staghorn calculi is seen on an X-ray. It is called as triple stones. Now, why it is called as triple stones? It has got the ammonium crystals, it has got the magnesium and the phosphate crystals. Because it has got 3 crystals, it is called as the triple stone. It is also referred to as the struvite stone. It is also referred to as the struvite stone. Also referred to as the silent stone, because it grows very slow. And remember, maximum damage to a kidney. The maximum damage to the kidney is done by your staghorn calculi. You can see how nicely they give the depiction of the staghorn, which is seen across here. Now, when you see a PUJ obstruction, you see this is the site of obstruction, and you see the dilated pelvic-calceal system. Here you see a dilated pelvic-calceal system, and this is characteristic of your PUJ obstruction. Now, this is classical spider leg appearance. Now, the spider leg appearance on an IVP, it is seen in polycystic kidney disease, right? So here it is going to be your cystic anomaly, or the PKD will be presented with spider leg appearance. You can see this thinned out calyxes which are present. These are characteristic for the spider leg appearance, right? So this is with respect to the IVP. So Another important question that we have a young male patient with the history of accident or the road traffic accident, unable to pass urine. The blood is seen at meatus. Unable to pass urine, blood at urethral meatus with, if there is a perineal hematoma, it is anterior urethral injury. If there is a pelvic hematoma, it is your posterior urethral injury, right? So what is the most likely site of diagnosis or the urethral injury? If I reconstruct the urethra for you, let's reconstruct the urethra. This happens to be the bladder. This is the prostatic urethra. This dilatation is the verum montanum. This is your membranous urethra. This is the injury that has occurred in the membranous urethra. This happens to be your bulbar urethra, and this is going to be your penile urethra. So if I simply label it down for you, this happens to be your prostatic urethra. This is membranous urethra. This is your bulbar urethra, and this happens to be your penile urethra. So the injury that you can see here is at the level of your membranous urethra. So here it is a membranous urethral injury. It is your membranous urethral injury. Guys, if you have any doubts, if you are there, you can just scroll it up. You can just give it a go. If you have any doubt, any question that you want to ask, feel free to ask so, right? Now, this image is what you have to remember. You can see the initial bladder is there. Then you see a small narrowing, that is prostatic urethra. The contrast will spill more, that is your verum montanum. Then a thinning is there, membranous urethra. This U-type line, you see this hunch that is present, right? Or this hairpin loop or the curve that is present, that is your bulbar urethra, and at the end you have the penile urethra that is present, right? So based upon this, you can divide whether you're looking at an anterior or a posterior urethral injury. Now, next question, we have already discussed this. I have a male patient with the midline neck swelling. Then there is cervical lymph node enlargement. Histopathology is given. What is false? So based upon the histopathology, these are your orphan annii nuclei. This is the orphan annii nuclei. This is the orphan annii nuclei that is present. This happens to be the orphan annii nuclei. Now, the orphan annii nuclei is characteristic of papillary cancer thyroid. So, they are asking which statement is false about the papillary cancer thyroid. Excellent prognosis associated, that is correct. It spreads via lymphatics, it is correct. Nuclear characteristic are used for identification, this is also correct. FNSE, it is diagnostic. Remember, FNSE is not diagnostic for follicular cancer thyroid. So answer here is going to be D for Delhi, right? So follicular cancer thyroid cannot be differentiated on FNSE. For that, you need to do a lobectomy along with frozen section in order to do so. So answer here is D for Delhi. You're right there. Correct, Shada. You're absolutely correct, beta. Right. Achha, can you identify this? Okay, I have given you the image as the orphan annii nuclei. This is the orphan annii nuclei, absolutely correct. Can anybody tell me what are these concentric circles, right? These onion peel concentric circles. These are nothing but your samoma bodies. These are nothing but your samoma bodies, right? So when you say samoma bodies, what are the other sites that you will see samoma bodies? Remember the mnemonic as your favorite subject, that is your PSM. P stands for, I say P stands for the papillary variant of renal cell carcinoma. S stands for serous cyst adenoma. It is the serous cyst adenoma of ovaries. And M stands for meningioma. M stands for meningiomas, right? So these are the sites where you will see the samoma bodies which are going to be present in your papillary cancer thyroid. Then there is another image. Yes, we are going to get another image is in the thyroid cancers is about presence of amyloid in a particular strands. Where do you see the presence of amyloid on a histopathology on a thyroid cancer? The answer is, can you tell me? Where do we see that? Where do you have the amyloid presentation? Remember, it can be seen in medullary cancer thyroid. Absolutely important, right? Moving down to the next question. What do you have? I have a 40-year-old man, a known case of hypertension, presented with multiple episodes of hematuria and loin pain. His elder brother passed away due to stroke at the age of 40. The ultrasound is given. What is the problem or the probable diagnosis? Now, when you do an ultrasound, I don't know what organ it is, but I know there are multiple cysts which is present, right? Now, it is a multicystic condition. It is a multicystic condition. Now, based upon the option, I can attribute this multicystic to a multicystic kidney, right? So, it is nothing but a polycystic kidney disease. This is a PKD, right? Now, when you talk about the polycystic kidney disease, it is an autosomal dominant disorder. If it is adult, it is autosomal recessive. If it is child, right? Not always it is autosomal dominant. Now, if you look at the prospect, I can divide them into the adult polycystic kidney disease and the child polycystic kidney disease. Remember, adult, it is going to be autosomal dominant. This is autosomal recessive. It is associated with, okay, can anybody tell me, I'm looking at the screen, what is the chromosome, or I can say what is the chromosome abnormality that is seen on an adult polycystic kidney disease, and what is that you see on a child polycystic kidney disease? Chromosome number 16 and chromosome number 4 is for adult, whereas for child it is chromosome number 6. Absolutely correct, Shivang. Right, Lalit, you're correct. It is absolutely correct. Now, adult will present to you with bilateral involvement. Here also it will present to us bilateral kidney involvement. Remember, in both of them, they will be associated with end-stage renal disease. End-stage renal disease. Kidney transplant is the only thing, but you can perform. So, see, when the polycystic kidney disease or the cyst will start to enlarge, patient will present to you with bilateral flank mass. Here also, it will have bilateral flank mass. Now, this mass, it is so smooth, it looks like a doorknob. It is called as the knobby mass that is present. Now, as the cyst enlarges, it can rupture. If it ruptures, it will present to you with hematuria. At the same time, when it enlarges, it is going to stretch the Gerota's fascia, which is going to present to you with bilateral flank pain as well. Remember, in order to relieve symptomatically, for a symptomatic relief, you can do a surgery which is called as the Rovsing surgery. Rovsing surgery is a cyst deroofing surgery in order to decrease the pain per se. Otherwise, the treatment of choice is going to be renal transplant. Now, if I say what is the treatment of choice for PKD disease, either ways, remember the treatment of choice for a polycystic kidney disease, it is going to be renal transplant. But the first line is to start the patient on hypertensive drugs, that is antihypertensive drugs. And the second line, it is going to be the renal transplant. It is going to be renal transplant. Which antihypertensive drug is contraindicated in a patient of polycystic kidney disease? The answer is AC inhibitors, because they are contraindicated with bilateral renal disease. Somebody is telling me spider leg. We have already discussed it. In a polycystic kidney disease, the IVP's presentation would be of polycystic kidney disease, is spider leg appearance. Absolutely correct, right? Now, what are the extra renal manifestations that you can see? Can anybody tell me what is the extra renal manifestations? So, when you talk about the extra renal manifestations, the extra renal manifestations which are seen in a polycystic kidney disease, number one, there will be presence of multiple cysts. Now, if a kidney has multiple cysts, the probability of having multiple cysts in other organs also increases. So, what are those? There could be multiple cysts. Most commonly, it will be seen in liver. If this is not there, then in pancreas. If this is also not there, then the answer would be in spleen. Remember, number two, it is going to be associated with Berry's aneurysm. It is going to be associated with Berry's aneurysm, which is the aneurysm of circle of Willis. When the Berry's aneurysm rupture, it will result in subarachnoid hemorrhage, which is going to cause the symptoms of stroke. In the cardiovascular system, it is associated with mitral valve prolapse. It is associated with mitral valve prolapse. Now in the GIT, it is associated with diverticulosis. It is associated with diverticulosis, right? These are the important components. Now coming back to our question, this is a 40-year-old man, which is we are addressing right now, known case of hypertension because of renal damage, multiple episodes of hematuria because his cyst is rupturing, brother died because of stroke, that is ruptured Berry's aneurysm, autosomal dominant disorder. See, in adult, the age of presentation is about 20, whereas in child, it is in the first decade of life. So 40 years is that sweet spot where you can see. So you have the diagnosis as the polycystic kidney disease, and it is an autosomal dominant polycystic kidney disease, right? So that goes in this favor. So every single component of the polycystic kidney disease is important. I want you to revise this particular slide so that you'll be able to answer each individual component as we move forward. ठीक है? Chalo. Now let's look at this question. Just go through this question. I'll quickly have some water and then we'll start again. All right, so let's go. So what is the question that we have? We have a patient with acute onset of severe abdominal pain. He is hemodynamically stable. The chest X-ray is given below. What is the next step in the management? Now, when you look at this particular chest X-ray, which is here, you can see that this area is the liver shadow, right? This is the liver shadow that you have, and this is the diaphragm that is there. Between the diaphragm and the liver, you can see there is some amount of air that is present. You can see this area. This is free gas under right hemidiaphragm that is seen across here, right? So you can see that this is the diaphragm. This is the liver shadow. And between these two, we have the free gas. So when you talk about the free gas under right hemidiaphragm, it indicates the diagnosis. It prompts the diagnosis of hollow viscous perforation. It is your hollow viscous perforation. Now, causes for hollow viscous perforation, it can be your peptic ulcer disease. It could be secondary to an acute appendicitis. It can be secondary to an acute appendicitis. It can be secondary to an enteric fever. Enteric fever, that is typhoid, usually at terminal ileum. It can be because of acute mesenteric ischemia. Acute mesenteric ischemia. All these are the causes for hollow viscous perforation, right? So what is the next step in the management? Now, because the patient is hemodynamically stable, right, there is no need for any lavage, right? You can take the patient in terms of laparotomy in order to know from where the perforation is there. There is no role of ultrasound, there is no role of chest tube insertion. So best option here would be emergency laparotomy. Now, if there was an IV fluids, I don't need to put a chest tube beta. Why would you put a chest tube? Chest tube is put if it is having pneumothorax or a pyothorax or a hemothorax. Here, the lung window or the lung is absolutely fine. The air is under the diaphragm, right? So there is no need to put a tube in the chest, not at all, right? So here, if the option was there as IV fluids, resuscitate and then take the patient for laparotomy, that would have been a better answer. Clear? Chal. We have already discussed this. This is going to be in the same context, right? Chal. So moving to the next one, calculate the percentage. That is, you have burns in a preschool child shown in the image, right? So you have the image. We have all the relevant data that is present. So first of all, remember the most common rule that we are going to use is going to be the Wallace rule, which is also called as the rule of 9. in order to evaluate the total body surface area burnt. But if I say what is the best rule for the assessment of the burns, then the answer is going to be Lund and the Broders chart. It is going to be Lund and the Broders chart, right? Now, in general, when we say the head and neck, we are talking about adult and a child, it is going to vary. So here we are talking about a preschool kid. Now, in a preschool kid, the head and neck, in adults, it is going to be 9%, right? So, in pediatric age group, what is the change that is expected? Quick feedback. So, what is the change that is expected in pediatric age group? Head and neck will become 18%. The upper limb will remain 9%. The anterior trunk is 18. The posterior trunk is going to be 18. The lower limb is going to be 14% each. The lower limb is going to be 14% each. There is no perineum in a child, right? So, in this, what do you have? You have the anterior surface, the whole upper limb is 9%. This much part it is burnt, right? So, it is the half is nothing but 4.5, but in that only anterior surface is depicted. So, on the anterior surface, you see this is the area that is burnt. Only the anterior surface is depicted. So, this will be your 2.25%, right? Then you have the entire anterior trunk, which is 18%. Which is going to be involved. Then you have the limb, which is 14%. The anterior will be 7, the posterior is 7. In that half, that is 3.5 here. This is 3.5% which is burnt, and this is your 3.5% burnt. So, total 7% is going to be burnt here. So, what is the total amount? 27.25% is the total body surface area that is burnt. So, here how much? 27.25 will go between 25 to 30. So, answer here is going to be B for Bombay, right? Now, a couple of important questions that can be asked here. Now when you talk about in terms of fluid, when you talk about it, right? So, the most common fluid for resuscitation would be your ringer lactate, right? If they say what is the most common colloid used, it is going to be human albumin solution. For crystalloids, what is the formula that we are going to use? We are going to use the ATLS formula. Now, according to the ATLS formula, we see if it is a second degree or a third degree burn. And if the patient is an adult, it is going to be 2 ml per kg per percentage of total body surface area that is burnt. If it is a child, so here the child is less than 14 years. So, this is going to be 3 ml per kg per percentage of total body surface area that is burnt. If it is a 4th degree burn or an electric burn, for this irrespective of the age, it is going to be 4 ml per kg per percentage of total body surface area that is burnt. Now, whatever crystalloid that we calculate, this is what we call it as the burn fluid, and this burn fluid, it must be administered. It must be administered or given within 24 hours. So, in this 24 hours, I am going to split them into 8 hours, that is the first 8 hours, and the next 16 hours. In the first 8 hours, whatever fluid that you have calculated, the first half of the fluid has to be given as fast IV, and the second half of the fluid will be given as slow IV over a period of 16 hours, but within 24 hours, you have to give away the fluids, right? Now, for the colloids, we use Muir and Barclay formula. Now, in the Muir and Barclay formula, it is 0.5 into weight in kilograms into percentage of total body surface area burnt. Whatever value that you are going to get, is called as one portion. In the first 12 hours, I will give every 4th hourly. In the second 12 hours, I will give every 6th hourly. And thereafter, every 12th hourly has to be administered, and the protocol follows thereafter. Right. So, very good, guys. Muir and Barclay is what you're going to look across here. Right. So, this is with respect to that of the fluids or in terms of burn fluid management that you need to know. If I say what is the most common topical agent? The most common topical agent used for burn wound dressing, it is your silver sulfadiazine. On the other hand, if I say what is the best topical agent, it is silver sulfadiazine with cerium nitrate. Right. So there are 2 points that you should be aware of. Okay, absolutely correct. Moving on to the next question. Now, this is a spotter, 32-year-old male, chronic alcoholic, oral ulcers, burning sensation, oral cavity given. You can see this whitish lesion that is present. White means leukoplakia, and this answer is going to be leukoplakia. If it is a bright red lesion, it is erythroplakia. If it is going to be a paled, waxy, white appearance, that is what we call it as the submucosal fibrosis. And the last one is malcoplakia. Okay, all of them are classified as the premalignant lesions. Now, to the next question, what do you have? A patient presents with tender pulsatile mass shown in the image given below. What is the next step in the patient's management? Now, when you look at this patient, you have a swelling that is present on the lateral side of the neck, right? If it was due to a trauma, right? If it is a traumatic neck swelling, I would have gone with CT angio. But if it is an atraumatic or if it is just an incidental swelling, it could be because let's say carotid mass can be there. It could be chemodectoma or a cervical lymphadenopathy, right? But if it is a pulsatile mass, as it says clearly that it is a pulsatile mass, you're thinking about vascular. And when I think about vascular masses, you are not going to insert needle. So the first thing I'm going to rule out, needle aspiration goes out. So there's no evidence of any infections. So no need for any intraoperative, or I can say intravenous antibiotics, right? CT angio with percutaneous, I'll never do a percutaneous management. I will never perform a percutaneous management. So the only option that looks viable here, right? Yes, Yashashvi, you're correct. Biopsies are contraindicated in pulsatile masses. Here you have to go with ultrasound. See, here you have to look at the merit of the option, not the question per se. For such masses, I would have gone with CT angio. I would have got a CT angio, which I would be much better. But with intervention, no, I will not intervene, especially percutaneous interventions. No scope at all. Right? Chalo. Now let's go to the next question. I have a patient present with carcinoma of the prostate, now spreads to the vertebra. What is the most common route? See, all prostate cancers, they spread to lumbar vertebra with the help of Bateson's plexus. Now, these Bateson's plexus are the valvulus venous communications. These are your valvulus venous communications. These are your valvulus venous communications between the prostate and the lumbar vertebra. Between the prostate and the lumbar vertebra. That's your Bateson's plexus. Okay? The Bateson's plexus are also responsible for the spread to the vertebrae via the breast cancers also. Remember, in the prostate cancer, the most common type of secondaries here is going to be osteoblastic secondaries. But when it comes down to breast, it is osteolytic secondaries which are more common when compared to osteoblastic secondaries. Do not forget that as well. So here it is going to spread because of prostatic venous plexus that are nothing but your Bateson's plexus. Answer here is going to be A for Ahmedabad. Absolutely correct. Right? Correct, guys. Acha, can anybody tell me what is the scoring used for prostatic cancer for the assessment of the prognosis? What is scoring use? The scoring use is your Gleason score, right? It is your Gleason's score. Achha, can anybody tell me what is the minimum Gleason score and what is the maximum Gleason score? वेरी गुड गाइस. अच्छा, ग्लीसन्स में क्या मिनिमम कितना स्कोर है? मिनिमम इज गोइंग टू बी 2, द मैक्सिमम इट इज गोइंग टू बी 10. Bigger the score, poorer the prognosis. Gleason's cannot be written as a whole number because you should always write 1 plus 1 or it is going to be 5 plus 5 because the primary grading is done between 1 to 5, secondary is between 1 to 5. तो हमेशा प्राइमरी ग्रेड को पहले लिखेंगे, सेकेंडरी ग्रेड को बाद में लिखेंगे. प्राइमरी ग्रेड अगर ज्यादा होगा, if the primary grade is higher when compared, let's say that I give you classical examples. No, if I have a patient A which is having a Gleason score of 7, a patient B a Gleason score of 7, who is going to have a poorer prognosis? We cannot determine on the basis of a whole number. नहीं बनेगा. तो इस whole number को हमेशा लिखते हैं in terms of primary grade. Primary grade 3 plus 4 है, इसका primary grade 4 plus 3 है. तो प्राइमरी ग्रेड का मतलब जो पहले लिखोगे, सेकेंडरी जो बाद में लिखोगे, प्राइमरी सेकेंडरी. नाउ who is going to have a better prognosis, patient number A or patient number B? A quick feedback. Who is having a better prognosis? Patient A has a better prognosis or patient B has a better prognosis? Quick feedback. Yes, primary scoring is more important. Patient A का primary score कम है, इसका better prognosis है. Primary score of patient B is more, तो उसका पूरा prognosis है. You guys got it right. Absolutely perfect. So this is going to have a better prognosis. Absolutely correct. Now, moving on to the next one. What do you have? I have a male patient. Okay. With impotency, not a good news. Bilateral resting pain, even more worse news. The following finding is seen in the leg. What is the level of pathology that is there? So in the leg pathology, I can see there is presence of gangrene. So I know we are talking about arterial occlusions, right? Absolutely. तो we have a small table. ठीक है, ये जो हमारा table है, it is a determining table for all the components. ये हम अपने क्लास में रेगुलरली पढ़ते हैं. बीन टेलिंग यू द 3 कॉमन साइट्स ऑफ ओक्लूजन, आयोटो आइलियाक, आइलियाक एंड फेमोरोपोप्लिटियल. जब आयोटो आइलियाक में ओक्लूजन होगा, ब्लड फ्लो टू द बोथ द आइलियाक्स विल डिक्रीज, ब्लड फ्लो टू द इंटरनल एंड एक्सटर्नल आइलियाक विल डिक्रीज. सो पेशेंट ऑफ बाइलेटरल इंटरमिटेंट क्लॉडिकेशन, कौन कौन से मसल्स इन्वॉल्व होंगे इसमें? ग्लूटियस, थाई, काफ, एंकल, एवरीथिंग इज गोइंग टू गेट इन्वॉल्व्ड. इन मेल्स द इंटरनल आइलियाक सप्लाइज टू गोनाड्स. सो मेल्स में क्या होगा? बाइलेटरल इंटरमिटेंट क्लॉडिकेशन विद मेल इंपोटेंसी इज व्हाट वी कॉल इट एज लेरिच सिंड्रोम. तो हमारा पेशेंट लेरिच वाला ही तो है, तो डायग्नोसिस तो यहीं पे हो गया. आंसर हियर इज गोइंग टू बी योर आयोटो आइलियाक ओक्लूजन. सो हियर इट इज सी फॉर कैलकाटा. नाउ व्हेन यू लुक अक्रॉस हियर इन द रेस्ट ऑफ द स्टोरी, आइलियाक ओक्लूजन में क्या है? कॉन्ट्रालेटरल साइड पे ब्लड फ्लो नॉर्मल है, लेकिन यहां पे इंटरनल आइलियाक और एक्सटर्नल आइलियाक में कॉम्प्रोमाइज है. गोनाड्स विल ड्रॉ द ब्लड फ्रॉम द कॉन्ट्रालेटरल इंटरनल आइलियाक. तो मुझे यहां टेंशन नहीं है, लेकिन एक्सटर्नल आइलियाक में ब्लड कम है, तो व्हाट इज गोइंग टू हैपन? ब्लड सप्लाई टू द लिम्ब इज गोइंग टू डिक्रीज, बट ग्लूटियल स्पेयरिंग इज नोटिस्ड. थाई, calf and ankle will be involved. If it is femoropopliteal, only calf and ankle is involved. Based upon the site or the level of claudication, you can predict the site of occlusion. ये भूलना नहीं है. So how do you manage it? For ioto-iliac, it is ioto-bifemoral bypass. For iliac occlusion, it is ioto-femoral bypass. For femoropopliteal, it is going to be iliopopliteal bypass. अगर आप आयोटा के साथ bypass कर रहे हो, you will be using Dacron. If you are using a bypass from iliac to the popliteal vessel, I'll be using autologous reversed great cephalosporin. पेशेंट का खुद का great cephalosporin upside down कर देंगे. क्यों? अगर आप नॉर्मल लगाओगे, valves ऐसे होंगे, they will not allow the blood to flow. When you do an upside down, the valves will facilitate the blood flow from the iliac vessels into the popliteal artery. अगर आपसे बर्जस में पूछेंगे, बर्जस में क्या करोगे यार? क्विट स्मोकिंग बोलेगा, पेशेंट बोलेगा नॉट पॉसिबल, बोलेगा कोई दवा दे दो, पैराक्सिलिन और पेंटॉक्सीफाइलिन, लेकिन उससे काम नहीं होता है. रेस्ट पेन होगा तो लंबार सिम्पेक्टमी करोगे. लंबार सिम्पेक्टमी में कहां से डर्मेटोम्स निकालोगे? विच डर्मेटोम्स आर कॉम्प्रोमाइज? L1 to L5. एक इंपॉर्टेंट प्रिकॉशन क्या है? Whenever you are doing a bilateral lumbar symplectomy, L1 of any one side must be preserved, especially in males, to prevent retrograde ejaculation. एक और important point, lumbar symplectomy is a treatment of choice for rest pain, but it is contraindicated in intermittent claudication. देखो, intermittent claudication में दर्द अच्छा होता है. दर्द ये बताता है कि कब रुकना है. It tells you when to stop. Imagine a patient of intermittent claudication is walking. He does not know. Why does a patient stop? Because it is hurting. Let's say if I don't realize that there is no pain, because if a lumbar symplectomy is done, I will not appreciate pain. So even though there is occlusion, I'll continue to walk. Now as I continue to walk, there will be hypoxia. It will become worse. But I'm not able to know it is getting worse. In a good fine day, what is going to happen? The muscle will go into gangrene, right? So intermittent claudication में patient रुकता इसलिए क्योंकि उसको दर्द हो रहा है। दर्द इसलिए हो रहा है क्योंकि हाइपोक्सिया है। हाइपोक्सिया तो होगा, लेकिन दर्द कौन बता रहा है? योर लंबार सिंपैथेटिक सिस्टम। अगर आपने लंबार सिंपैथेक्टमी कर दी तो नर्व कंपोनेंट ही नहीं है, तो दर्द का पता ही नहीं चलेगा। दर्द का पता नहीं चलेगा, पेशेंट चलता ही रहेगा, राइट? As patient continues to walk, the hypoxia will become more and more severe, causing early onset of gangrene. So इसलिए remember that lumbar sympathectomy is contraindicated in intermittent claudication, but that is the treatment of choice in rest pain. Is that clear? ठीक है? Excuse me. चलें. So this is in terms of arterial occlusions. ठीक है? चलो. So what do you have? The next one, I have an elderly male patient presented with sudden onset of scrotal pain and discharge. Image given. What is the diagnosis? Image given. It is classical for your Fournier's gangrene. So when you say it's a Fournier's gangrene, सबसे important क्या है Fournier's gangrene में ना? Yes, you got the diagnosis correct. It is going to be a Fournier's gangrene. Remember, Fournier's gangrene is also called as necrotizing fasciitis of the perineum. इतना याद रख लेना, Fournier's gangrene में it is going to be a mixed infection of both aerobic and anaerobic organisms that is going to cause the problem. But patient should also have a compromise or immunocompromised status. It has to be diabetic, it has to be a recent history of trauma with diabetes or the pre-existing cause, malignancies, yes, absolutely correct, mixed anaerobes as we have discussed. It should be either immunocompromised status, AIDS, anything of that sort. These are the guys who are going to be present. Now, Fournier's gangrene का एक common name क्या है? The another common name for Fournier's gangrene is called as shameless testes. Why? Because the entire scrotum will be debride, the testes will be hanging out. But the good thing is it regrows. The scrotal component regrows and engulfs the testes back in. Testes are spared. Urethra is spared in the component of Fournier's gangrene. That is to be remembered. ठीक है? चलो. What is the discharge that you see in Fournier's gangrene? Foul smelling rice watery discharge, right? Like in cholera, same here. You have right watery discharge from the scrotum in with foul smelling pungent odor that comes out is your Fournier's gangrene status. Chalo. Identify the fluid that is shown in the image below. So, यहाँ पे आप क्या देख रहे हो? तो what I have given you is the composition. I have sodium, I have potassium. The minute you see chloride and potassium, I know we are talking about Ringer lactate, but it also has lactate here. No, now it confirms that I am looking at Ringer lactate. So it is your Ringer lactate. ठीक है? Absolutely correct. So when you look at the compositions, now this is the table that I would want you to look at it. You have the composition which is Hartmann solution, normal saline, Ringer lactate, plasma light, the gelofusine, the hemacil, hetastarch, dextarch and all these components. But पहले के चार important है. Hartmann's में sodium is 131, potassium 5, calcium 2, chloride 111, lactate 29. Normal saline 154 milliequivalents of sodium and chloride, nothing else. Ringer lactate 130 of sodium, 4.5 of potassium, 2.7 of calcium, 109 of chloride and 28 of lactate, right? Now, apart from that, nothing else is important. These three fluids you must know with respect to their compositions as well. Now, okay, so what do we have? The image is shown as the pressure sore. What is the stage that is to be given? As you can see here, there is involvement of underlying structure. If the underlying structure is involved, it is called as grade 4 pressure ulcer, right? So when you talk about the grades of pressure ulcer, we have, what is the criteria for development of a pressure ulcer? What is the criteria for development of a pressure ulcer? Remember, the most important is if the pressure exerted is more than that of capillary occlusive pressure. If it is more than that of capillary occlusive pressure, remember the capillary occlusive pressure is going to be 30 millimeters of mercury. That is going to be 30 millimeters of mercury, right? Then the patient will develop pressure ulcer. Remember the other name for the pressure ulcer. Everybody knows it is called as the bed sore, but more importantly, it is also called as decubitus. also referred to as the decubitus ulcer, also referred to as the decubitus ulcer, right? Now, in grade 1, there is presence of non-blanching erythema. There is presence of non-blanching erythema. This is grade 1. If I say grade 2, there is partial thickness skin loss. There is partial thickness skin loss. In grade 3, there is full thickness skin loss. There is full thickness skin loss for grade 3. Now, for grade 4, there is involvement of underlying structure. There is involvement of underlying structure. And the last one is unstageable, where if there is presence of necrosis or if there is presence of slough. If there is presence of necrosis or presence of slough, this indicates that the patient is having a pressure sore, right? Now, remember, if I say what is the most common site? What is the most common site for pressure sore? Any idea? Quick feedback. What is the most common site for pressure sore? Overall most common site for pressure sore. Quick feedback. Overall most common site. It is your ischium. If ischium is not in the option, what is the next best answer? It is your greater trochanter. If not, it is sacrum. If not sacrum, then it is heel. If not, then it is lateral, more common than medial, that is malleolus, right? And the last one is occiput of the patient. This is the sequence that you have to remember. Ischium is the most common site, followed by that you have greater trochanter, then you have the sacrum, the heel, the lateral malleus is more common than medial, and the occiput. Remember, for all these, for 1 and 2, it is going to be conservative. For there onwards, you have to go with cleaning and debridement followed by the conservative protocol. In the conservative protocol, it is your frequent change in position. Now, when we say frequent change in position, for frequent change in position, remember, if a patient is bedridden every second hourly, if it is wheelchair bound every 10 minutes, you have to change the position. Along with that, you have to give air and water bed so that the pressure is not being sustained for a prolonged period of time, right? So this is with respect to the pressure ulcers, right? So this entire table is important from the exam perspective as well. Now, next question, I have a man who came with complaint of recurrent discharge, pain due to the lesion around the anus for 3 years. What is the diagnosis? So you can see here, this is the anal verge and you see this is the lesion. I'll just highlight it. This is the anal verge and this happens to be lesion that is present, and this is around the site. You can see, so this is usually the tract that is present, that is going to be your fistula in ano. It is not a pilonodal sinus. Remember, a pilonodal sinus will be in the gluteal cleft where you have hair areas, right? So this is not the answer. Carbuncle will have multiple discharging sinuses. It is only a one single point that is present. Boil is just an arbitrary word. So answer here is going to be fistula in ano, right? Remember, the most common type of fistula in ano is going to be the intersphincteric variety. The most common type, it is going to be the intersphincteric type, and this intersphincteric type is according to the Parkes classification, right? Do not worry about it. Now, next question. Now, the next question that you have, according to the triage, following categories of patient comes under green. Green are the patients who are least important. You can leave them at their own context. So they are ambulatory. They are not medium, high or dead. It is going to be A. Dead is black, right? High risk, it is going to be red. Medium, it is going to be yellow, right? So we have the color coding system which is present right across here. So you have the description. It is red means immediate, yellow means urgent, green means delayed, blue is an expectant, that means on hold, and black means dead or brought dead. Right, so let's go to the next one. What do we have here? Okay. Guys, don't worry, all this entire context that we have done, it will be converted into a PDF and will be uploading in our Meded channel, Meded group as well. You can follow my own Instagram channel, that is the surgery guy. If you want to get any, updates or anything, you can always follow this. It is the surgery guy. The same is there on the Telegram group, also the Telegram channel, where we upload all the notes. So after this class also, I'll be putting up the entire notes in our Telegram channel as well as in our Instagram channel as well. Okay. Now, let's go to this question. What do you have? We have an intern who has asked to calculate the 𝐶-SOFA score. Q stands for quick. SOFA stands for sequential organ failure assessment score. It is your quick sequential organ failure assessment score, that is called as the 𝐶-SOFA score. Now, what are the components that you are going to remember in 𝐶-SOFA? Easiest way to remember in 𝐶-SOFA is, in 𝐶-SOFA there is no temperature. So wherever your temperature, this cannot be, this cannot be, this cannot be. Answer is C for Calcutta. As simple as that. Remember, 𝐶-SOFA does not consist of temperature. So what does it consist of? Now, 𝐶-SOFA consists of 3 points. One, it consists of the GCS, that is mental status, respiratory rate and systolic blood pressure. So GCS, respiratory rate and the systolic blood pressure. Whereas systemic inflammatory response syndrome, it basically consists of the heart rate, it consists of respiratory rate, it consists of body temperature and the WBC count, right? So there are 2 components that you remember. Correct. Remember, in 𝐶-SOFA, the respiratory rate, as Ganesh has told, should be more than or equal to 22. Correct. Somebody has rightly pointed out revised trauma score and your 𝐶-SOFA has the same components. Very good. Always getting confused with the RR value of 𝐶-SOFA. But it's very simple, no? Remember, in 𝐶-SOFA, the respiratory rate should be more than or equal to 22. For SIRS, the respiratory rate is more than or equal, so more than 20, 20 cycles, we get CPM, cycles per minute. Okay, here also cycles per minute, right? In 𝐶-SOFA, S is 22, right? Second, 22, that is what you remember. Otherwise, nothing more is important than this. If you remember this, it's quite elaborately, it is self-explanatory. Now, going to the next question that we have, what do you have? I have a 30-year-old patient, came to our OPD with the history of midline neck swelling, which moves with deglutination and protrusion of tongue. I have the diagnosis. It is your thyroglossal duct cyst. Remember, the swelling that moves upwards with deglutination, the 4 swellings, thyroid swelling, thyroglossal duct cyst, subhyoid bursitis, enlarged pretracheal group of lymph nodes. But there is only one swelling that moves upwards with deglutination as well as tongue protrusion. That is going to be your thyroglossal duct cyst, right? Now, remember a plunging ranula. What is a plunging ranula? Is it a extravasation sublingual gland, salivary gland, or we can say the sublingual gland cyst, or is it a retention cyst? So what is an example? Lalit, absolutely correct. Movement of deglutination in thyroid gland is because of Berry's ligament, but I'm not asking that. What am I asking? I'm asking plunging ranula is a type of extravasation cyst or a retention cyst. Is it an extravasation or retention cyst? Plunging is an example of a retention cyst, whereas a ranula is an example of extravasation cyst, right? Brachial cyst is basically a congenital developmental cyst, but this will be on the lateral side. It will be on the lateral side of the neck, right? Plunging ranula is in the midline. Dermoid cyst, dermoid will be at the fusion of the suture lines. It is on the fusion of bony sutures, right? Where the 2 plates fuse, where? Okay? Chalo. So answer is thyroglossal duct cyst, right? If I say what is the most common site, remember the most common site for the thyroglossal duct cyst, it is going to be your subhyoid. Remember the surgery of choice for thyroglossal duct cyst, it is going to be your Sistrung's operation. It is going to be your Sistrung's operation, right? So this is a YouTube live class, so I hope everybody is able to get an access to it. If not, just share it across so that a lot of people can get the benefit out of it. Okay. So subhyoid is the site cisterns operation where a part of the hyoid bone is also removed. Answer here is thyroglossal duct cyst. Now, question number 23. Oh, sorry. Next question. 23-year-old female, exophthalmos, palpitation, heat intolerance, Graves' disease. That means primary thyrotoxicosis. Which are the following antibodies can you expect? So in Graves, the antibodies that you have is your long-acting thyroid stimulating antibodies, which are nothing but anti-TSH receptor antibody. Okay. Anti-TPO is seen in Hashimoto's thyroiditis. It is a Hashimoto's thyroiditis. Okay. So here it is LATs. LATs is your long-acting thyroid stimulating antibodies, which are going to be Graves' disease. Okay. Chalo. Now, so we have this table. So this is a table that we use for differentiation of all three varieties: Graves, Plumbers, and toxic adenoma. We have given all the components. Remember, the HLA that is involved in Graves is B8 and DR3. Everything else is on a comparative data. We have given you what are the antibodies. I just wanted to go through this table in a quick succession. That should be more than enough. It also gives you an interpretation of how do you manage it. Now, the most important aspect that I would want you to know here, that is, when you talk about Graves' disease in age less than 40, it is surgery. Age more than 40, it is radioactive iodine. For Plumbers disease, either of the age, it is surgery. Whereas in toxic adenoma, age less than 40, it is surgery. More than 40, it is going to be your radioactive iodine. It is going to be the radioactive iodine. I've given you the scans as well just to have an interpretation at your own free time. Just go through it. Nothing spectacular about it. Chalo. What happened? Okay, let's go to the next question. What do you have? I have a 48-year-old male, underwent a laparoscopic inguinal hernia. Post-operative, he complains of difficulty while walking for 3 months. Now, which of the following nerve can be entrapped in the mesh leading to the above symptom? So, when you talk about the laparoscopic inguinal hernia, the most common nerve is going to be your lateral cutaneous nerve of thigh. This is when you talk about the lap repair. When you talk about the open repairs, the most common nerve that is going to get injured is your ilioinguinal nerve. It is the ilioinguinal nerve, but the most common nerve which is getting trapped in a mesh, it is the iliohypogastric nerve. It is the iliohypogastric nerve. Rest the data on your hernia we have already discussed in your previous exam. So answer here is going to be the lateral cutaneous nerve of thigh. It is not the ilioinguinal nerve. गलती नहीं करनी है. यहाँ पे सवाल पूछा है for laparoscopic inguinal hernia repair. We're not talking about the open hernia repairs. ठीक है? We're not talking about the open hernia repairs. Clear? चलो. Going on to the next question. This is misbehaving, so we will close this and we'll reopen. So nerve that is entrapped in the mesh is your iliohypogastric nerve. It is the iliohypogastric nerve. Clear? Beta, when you're doing a laparoscopic repair, no, where is the mesh placement in a laparoscopic hernia? It is pre-peritoneal, above the peritoneum. Okay? So when you're dissecting it, that same mesh, but iliohypogastric nerve, where is the iliohypogastric nerve? Iliohypogastric nerve is above the muscles ना. यहाँ पे आप देखो यार, जब आप इंग्वाइनल कैनाल ओपन कर रहे हो, इंग्वाइनल कैनाल इज मेड अप ऑफ एक्सटर्नल ऑब्लिक अपोन्यूरोसिस, उसके नीचे क्या है? फेशिया ट्रांसवर्सालिस. इलियोहाइपोगैस्ट्रिक नर्व इज अबव फेशिया ट्रांसवर्सालिस. और अब जब आप लैप्रोस्कोपिक हर्निया में आप जब मेश लगाते हो, वो प्री पेरिटोनियम लगा रहे हो ना, पेरिटोनियम के नीचे लगा रहे हो, तो पेरिटोनियम है, पेरिटोनियम के ऊपर आपने मेश लगाया, उसके ऊपर यू हैव फेशिया ट्रांसवर्सालिस, उसके ऊपर इलियोहाइपोगैस्ट्रिक नर्व है ना यार. तो अगर आप लैप्रोस्कोपिक मेश डालोगे तो इलियोहाइपोगैस्ट्रिक नर्व तो इंजर होगी ही नहीं, क्योंकि वो तो काफी ऊपर है. ठीक है, चलो. Now, again, same simple question. What do you have? Deep inguinal ring is a defect in. Remember, deep inguinal ring जो है, it is a defect in fascia transversalis. Your superficial inguinal ring, it is a defect in external oblique aponeurosis. So here the answer is fascia transversalis. That is D for Delhi. Simple question, nothing spectacular about it. ठीक है, अच्छा. Okay, so I have a patient due to a laparoscopic hernia surgery. Which of the following could be described as a disadvantage over the open hernia repair? ठीक है, अच्छा. laparoscopic hernia में क्या है? Late recognition of electrochemical burns. Yes, it is true. In an open hernia repair, you can identify on the same site. यहाँ पे क्या है? It will present on a later part. Now, more pain is wrong. Remember, laparoscopic hernias are associated lesser amount of pain, lesser amount of bleeding, and early recovery. So all these three are wrong. The only problem that you will face in a laparoscopic hernia, it is that late recognition of your cautery burns or the electrochemical burns. Now, let's go to the next question. A patient admitted in trauma, history of RTA. On examination, he opens his eyes to a painful stimuli, speaks inappropriate words, withdrawal to limbs to the limb stimulation. What is your GCS score? Now, ये GCS calculate कर थक गए. ठीक है, so we call it as E4, V5, M6. We'll keep it simple. If it is spontaneous eye opening, a score of 4. If it is to a speech, it is going to be 3. If it is going to be on a pain, a score of 2. If there is no response, a score of 1. So here it is a painful stimulus here. तो यहाँ पे E का score 2 हो गया. Verbal response, if it is oriented to time, place, and person, score of 5. If the patient is confused, score of 4. If he is using inappropriate words, a score of 3. If he is using incomprehensible words, a score of 2. If there is no response, score of 1. So here he is using inappropriate, a score of 3 is given. ठीक है, तो यहाँ पे हमारा E2 हो गया, यहाँ पे V3 स्कोर हो गया. ठीक है, motor response, if he is going to obey the command, a score of 6 is given. If he is going to localize to the pain, localizing to the pain, a score of 5. If there is withdrawal to pain, a score of 4. If there is a decorticate rigidity, score of 3. If there is a decerebrate rigidity, score of 2. There is no response, a score of 1. Here he shows there is withdrawal to the pain, that is a score of 4. That is M4 is there. ठीक है, so E2, V3, M4, it is A for Ahmedabad. ठीक है, very good. Now the same thing I have given you here also. We have now called as the GCSP score, where you are also taking the pupillary response into consideration. You have eye opening, verbal response, motor response. If I add the pupillary score, in the pupillary score, if both bilateral pupils responsive to light, if bilateral pupils responsive to light, a score of 0 is given. ठीक है, if only one the pupil, unilateral pupil responsive, only one pupil is responsive, a score of -1. If bilateral pupil are non-responsive, if bilateral pupil are non-responsive, a score of -2 is given. ठीक है, even adding a pupillary scoring system, the GCS maximum will remain 15/15 only. ठीक है, चल. All right, so let's go to the next one. Good prognostic factor for BI-RADS 5 breast cancer. Now, I hope everybody knows the BI-RADS categorization. I don't need to go through it. Do we need to go through BI-RADS or can we skip BI-RADS? चलो यार आप बोलोगे सर क्या ही स्किप करोगे बताइए दो ठीक है तो बायराड्स का जो कैटेगराइजेशन इट इज क्वाइट सिंपल वी हैव बायराड्स कैटेगरी 0 व्हिच इज इनकम्प्लीट असेसमेंट it is incomplete assessment. Category 1 it is negative, there is no lesion is there. Category 2 it is benign. Category 3 it is probably benign. It is probably benign. Category 4 it is suspicious of malignancy. Category 5 it is highly suspicious of malignancy. And category 6 it is biopsy proven malignancy. It is your biopsy proven malignancy, right? Now here we have category 5 that is highly suggestive of malignancy. What is a good prognostic factor? None of the genetic components are a good prognostic factor. Receptor status positive is a good prognostic factor because they are going to be responsive towards your hormonal therapy. Now the another exam question is there's a category 3, what will you do? Ask the patient to come back after 6 months for repeat ultrasound or imaging. Okay, so that's your exam question. It is going to be after 6 months for imaging. Okay, chalo. This question we have already dealt before as well. In the SEEP classification depicted in the image what is given below. Now you can see this is nothing but the case of hyperpigmentation. You see all these pigments are there. So pigmentation what? C4A is your pigmentation. Right. What is C2? C2 is your varicose vein. What is C3? C3 is going to be edema. What is C1? C1 is going to be telangiectasia or presence of reticular vein, right? What is C5? It is your venous ulcer, but this is healed. C6, it is your active venous ulcer. Is an active venous ulcer. C4b, it is you are going to be lipodermatosclerosis. And the last one is C4c, it is coronophlebectatica. It is your coronophlebectatica. Okay. So these are the components with respect to here. So here we have a patient with pigmentation, it is C4a. Right. This is a question that we have discussed in the first half. Which of the following condition is true about the condition which is given below? You can see it's an abdominal wall involvement called as the Melanese ulcer. It is also an example of synergistic gangrene. It is also an example of synergistic gangrene. It is caused by mixed bacterial infection. Correct. Bladder diversion is required. It is not required. Bilateral orchidectomy is not required. Anti-gas gangrene serum is also not required. The answer which is here, which is the true, it is A. Right. So here you have to go with debridement. You can put a VAC that is going to be for a closure. VAC is an old term, that is vacuum assisted closure. Now we call it as negative pressure wound closure system. The pressure is minus 125 millimeters of mercury pressure put on intermittent basis. That is in the terms of VAC. Okay. This is a repeat question. 30-year-old patient, OPD, abdominal pain, weight loss, sterile pyuria. It is TB kidney. TB kidney में क्या मिलेगा आपको? पुटी kidney मिलेगी. Pyelonephritis, nephrocalcinosis, staghorn calculus not seen. You can see this is the definition of your putty kidney that is going to be present across. Okay. Now, going on to the next question, a patient has undergone surgery for breast cancer. 6 months later, she presented with a lesion depicted below. What is the diagnosis? Now, here the diagnosis is pretty straightforward. It is keloid. When you talk about difference between a keloid and a hypertrophic scar, see, hypertrophic scar will be limited to the wound site, whereas keloid will be involving the normal surrounding site as well. It is not thrombophlebitis, not hemangioma, not neurofibroma. Answer here is going to be keloid. So we have a table that I would want you It's a wrong table here. This is for HCC. Right, so quick off couple important points about your hypertrophic scar and keloids. I think I have the image, we'll just paste it across here. 1 second. Okay, got it. Right, you can see the differentiation between the hypertrophic and keloids. Now, extent when we say in hypertrophic scar, it is limited to wound side, whereas keloids, it will be involving the surrounding skin as well. Etiology, it is because of excessive fibroblast. Keloid is because of defective fibroblast. Time taken for the hypertrophic scar is within 6 months. It takes beyond 6 months for the keloid to develop. Sex, male, female are equally involved, whereas in keloids, females are more commonly involved when compared to males, right? Okay, clear. So you can see the sex which are looking across here. Males and females are equally involved here, whereas in keloids, it is the females which are more commonly involved when compared to males. Site anywhere in the body, whereas sternum is the most common site for keloids. Ratio of collagen, remember in normal scar, you will see type 1 collagen to be more, but here you can see type 3 is more, 1:6. Here it is 1:20. There is no pain, there is no itching, there is no family history, but all of them will be present in your keloids. Remember, for both of them, they are cosmetic reasons, so you can go for the reassurance. But if you feel so, remember for hypertrophic scar, under the cosmetic components, you can go with pressure garments or scar excision. Here, pressure garments, injection of intralesional triamcinolone, you can give Nd:YAG laser, topical vitamin C, and topical methotrexate can be given. So that's the differentiation between the hypertrophic scar and the keloids as well. I like the smart board. All right, so move to the next question. Again, it is misbehaving. Close, open. Right. So, what is the next question? I have a 55-year-old chronic alcoholic with weight loss. Okay. Revealed increased alpha fetoprotein with normal AST/ALT levels. The conjugated bilirubin was found to be high. What is the most probable diagnosis? Elevated alpha fetoprotein, non-alcoholic weight loss goes in favor of hepatocellular carcinoma. Okay. Now, the two important components that we would like to discuss. One, it is the HCC. Another one is the fibrolamellar variant of HCC. There are two differentiating components that you should know. Okay. Now, when we talk about the HCC versus fibrolamellar variant of HCC, you will say HCC is more common in males. Fibrolamellar variant is more equally seen in both males as well as females. The usual age of presentation is the 5th decade for HCC, whereas fibrolamellar variant is in the 2nd decade, that is 25. It is poorly differentiated HCC. Fibrolamellar is well differentiated. Only 25% of HCCs are resectable, 75% are unresectable. Remember, HCC is associated with cirrhosis as well as hepatitis, whereas fibrolamellar variant is not associated. The tumor marker that is elevated is your alpha fetoprotein, that is your AFP level, whereas here AFP remains normal, but elevated is your neurotensin. There is another tumor marker called as B12 binding protein as well. Prognosis poor for HCC, whereas good for your fibrolamellar variant. This table is important for us to remember. Chalo. Going on to the next one. 65-year-old diabetic patient. This is the lesion, loss of sensation and callosity is present, that is calcification. What is your diagnosis? Now, when you talk about diabetic foot with an ulcer, that is called as trophic ulcers. Trophic ulcers will have punched out ulcers or the punched out edge. It will have a punched out edge, right? Chalo. Venous ulcers will have sloping edge. Now, I have a patient with what is the following initial treatment? The case of NOH, that is sodium hydroxide, that is ingestion with complete dysphagia. So, this is basically an alkali ingestion. Now, problem with alkali is it is associated with liquefactive. It is associated with liquefactive necrosis. It is associated with liquefactive necrosis. Now, because it will cause more damage and I cannot feed the patient, I have to go with feeding jejunostomy. Esophagojejunostomy does not work. Gastrojejunostomy won't work. Stenting won't work. So, here the answer is going to be feeding jejunostomy. I want this kid to be fed well. Chalo. This is a repeat question. Statement incorrect. This is your Melanese gangrene. Hyperbaric oxygen has no role. No, it has role. It is not no role. Daily debridement is required. This is also correct. Diagnosis Melanese gangrene or Melanese ulcer. That is correct. Streptococcus is the main organism which becomes polymicrobial later. All is correct. So this is wrong. Hyperbaric oxygen can be given for a long-term non-healing ulcers. So A is incorrect. Rest all three of them are correct. Okay. Hyperbaric oxygens can be given for chronic non-healing ulcers or wounds. So A is wrong. It has got, it's saying no role. No, it has got role. I'm not eliminating it. It's not a mainstay of treatment, but it does not mean that it does not role. It has no role also as well. Okay. Now, 55-year-old male, verrucous mass of the penis. Verrucous is nothing but in situ malignancy, which is considered here. With no enlarged lymph node, the treatment of choice. So, whenever there is an in situ malignancy, for an in situ malignancy, the option that you have, you don't need to go with partial pennilectomy or podophyllin. You can give a topical 5-fluorouracil with laser ablation that you do. There is a carbon dioxide laser. So, out of these two, a better option would be a carbon dioxide laser that is going to be put across. Okay. Partial pennilectomy is done. Achha, this is okay. If you have a doubt, no. Now, for penile malignancies, no. Now, for penile cancer, I am going to vary it into in situ and invasive. In situ is basically managed with topical 5-fluorouracil with either ND-YAG laser, or you can do a carbon dioxide laser. Any of the lasers can be used to ablate the lesion. If it is invasive, you are going to look at whether it is involving prepuce or whether it is involving penis. If it is involving prepuce, then it is circumcision. If it is involving penis, it will now differentiate whether it is involving glands or shaft. If it is involving glands, then you have to go with partial amputation of penis. We'll do it, partial amputation of penis has to be done. Now, if it is at the shaft of the penis, for the shaft of the penis, we have to take the margin which is 1 centimeter. I will look at the stump length. After removing, if the stump is more than or equal to 2 centimeters, then you can go ahead with partial amputation. If the stump that is going to be left is less than 2 centimeters, then it is going to be your complete amputation of penis. Then it would be for complete amputation of penis. This algorithm is very important in solving your questions. How do you go with lymph nodes? Remember, you see node positive disease or a node negative disease. Usually we do surgery, we wait for 2 weeks to see whether the nodes resolve, because it can be secondary to infections also. If nodes resolves, no need to worry. If they're not resolving, you have to go with excision. Whereas if the nodes are not enlarged, you have to go with sentinel lymph node biopsy. The first ever sentinel lymph node biopsy was performed for penile cancer, and that is called as the node of Cabana. We have already discussed that, right? Chalo. What is the next question that you have? I have, what is the most common complication after the first major vessel ligation during an abdominoperineal resection for a rectal cancer? Now, this we have been asking many times, right? This is a repeat exam question. Can anybody give me a quick feedback? What is the answer? What is the likely answer? Quick feedback. Waiting for the feedback. Waiting for the feedback. Somebody's giving A, B. Nope. Okay. I'll give you an answer. Remember, it is going to be a parasympathetic bladder dysfunction and a retrograde ejaculation. There are two complications that you have to remember. Just remember the complication. Nothing more is important in terms of APR. APR is done for rectal lesions where the stump length is the less than 5 centimeters, or where now we say the anorectal junction is going to be compromised, or the anorectal bundle is going to get compromised. Okay? Chalo. Next question, a patient presented with hematemesis and melena. He is taking aspirin for osteoarthritis. So what is happening is patient is taking NSAID. Now what does NSAID do? It is a irreversible COX inhibitor or the cyclooxygenase inhibitors. Because of this, there will be decrease in prostaglandin secretion. Prostaglandins are responsible for stimulating the mucus producing cells. So mucus decreases. If the mucus secretion decreases, what will happen? It will increase the concentration of the hydrochloric acid inside the stomach, which will result in erosive gastritis. So here it is an upper GI bleed secondary to an erosive gastritis, which can result in development of peptic ulcer disease, right? So what is the diagnosis? It is not varices. It could be a peptic ulcer disease, not a malarious, not hemorrhoids. Answer here is B for Bombay. It is your erosive gastritis causing upper GI bleed. Okay. Now, when you talk about the portal venous anastomosis will be associated with, right? So where do you think the portal venous anastomosis will be associated with? Quick feedback. It is going to be, so it is a portosystemic collateral. No, it is going to be the esophageal vein and the left gastric veins. These are the sites where you'll see. So this is true. Superior rectal vein and hepatic vein, no. Epigastric vein and portal vein, no. Your inferior vena cava and portal vein, no. Now, when you talk about the portosystemic collateral, the portosystemic collaterals can be seen at the aegis vein, that is at the junction of esophageal and the left gastric vein. Then you can see the bare area of the liver, periumbilical veins, your omental veins, your retroperitoneal veins, lumbar veins, and the rectal veins. These are the 7 sites where you can see portosystemic collaterals. You need to remember them, right? Alright, so what do you have? I have a chronic alcoholic patient to the OPD with the history of pain in the right upper quadrant. On examination, there is hepatomegaly. On CT, it is observed. What is the best management in this condition? So, when you look at this, this is the lesion that is present. Now, you can see that it will have, you can see the presence of septations in the internal, but they are very hazily present. Now, when you look at this, you have a chronic alcoholic. He is presented to OPD, history of pain in the right upper abdomen. So, when you talk about alcoholics, no, it is the 2 conditions which are associated, pyogenic liver abscess as well as amoebic liver abscess. There are 2 conditions which are associated with respect to alcoholics. Alcoholism is not a risk factor for hydrated cyst. Okay? Now, on the CT, it looks like a poorly organized component. I cannot go with angioembolization or reassurance. It has to be either pair or surgical management. Okay? Now, pair is done for hydrated cyst. The other 2 will be done for surgical management. So, better option here is going to be a surgical management. Okay? So, in the surgical management, you can go with aspiration, but you call it amoebic liver abscess. We usually go ahead with what? We will go ahead with your metronidazole, high dose metronidazole. Okay? Chalo. Next question, a patient with history of chronic pancreatitis presented to the casualty. On further evaluation, a calcula was found in the pancreatic duct with 10 millimeters dilated. What is the treatment of choice? So let's look at quickly looking at the algorithm. So whenever you have the chronic pancreatitis or pain, the first thing you will see the MPD, that is your major pancreatic duct diameter. So the MPD classification that you have, if it is less than 7 millimeters or MPD is more than or equal to 7 millimeters. Now if it is less than 7 millimeters, then you will go with ERCP with stenting, which is the current guidelines. If it is more than 7 millimeters, then you would go ahead with two procedures. One is drainage, another one is resective technique. Now, if the head is fibrosed or if your head is involved, then you'll go with resective. For drainage, you have two options. One is your duval surgery, another one is your Pustows. For resective technique, I have two options. One is the Beggar's surgery. Another one is your Frey's surgery. So Beggar's is your duodenal preserving pancreatic head resection. Okay. Whereas Frey's is your duodenal preserving pancreatic head coring with longitudinal pancreatojejunostomy. Pustows is an example of LPJ, that is a longitudinal pancreatojejunostomy, right? So here he is asking with more than 10 millimeters. I'm not going to do a gastrojejunostomy. Pancreatic duodenostomy is not done. That is lateral pancreatojejunostomy is wrong. We will do a longitudinal pancreatojejunostomy, which is correct, which is nothing but your Pustows surgery. This is your Pustows surgery. So answer here is going to be D for Delhi. Okay? Very good. Absolutely correct. Now, second last question. A patient came to the OPD with the swelling over the face, which is over the parotid with variable consistency, was mobile and painless. What is your most likely diagnosis? The answer here is going to be parotid tumor. You can see here. Now, remember in parotid swellings, there will be obliteration of retromandibular groove. There is a curtain sign positive. That means you are not able to go above the zygomatic arch. You will also notice the swelling enlarges. The most common parotid swelling is going to be pleomorphic adenoma. How do you identify the trunk of the facial nerve? Remember the Conley's pointer, what is also called as the tragal pointer. From the tip of the tragal cartilage 1 to 1.25 centimeters medial and below, you will see the trunk of the facial nerve. If you remove the parotid gland above the facial nerve, is called as superficial parotidectomy. You remove both the parotid lobes sparing the facial nerve is called as total conservative parotidectomy, right? So answer here is parotid tumor. Absolutely correct. So last question that we have for this discussion, a 43-year-old male, alcoholic, came to the OPD, complains about the pain in the hypochondrium, history of loose stools a week ago, ultrasound 75 cc of pus is present in the liver. What is the management? Now there is history of colitis. There is history of colitis. There is risk of alcohol. History of colitis, risk of alcohol with 75 cc collection in liver. Now all these goes in favor of amoebic liver abscess. Amoebic liver abscess starts with colitis, right? The most common site being cecum. It causes flash-shaped ulcers. The patient will be having amoebic colitis, would have been treated. So for amoebic liver abscess, the management is high dose metronidazole. It is your metronidazole. When we say high dose, it is 700 to 1000 milligrams per day. That is 700 milligrams. That is given 3 times a day. That is TID for 10 to 14 days. This is the standard. If this fails, high dose metronidazole fails, then I am going to do an aspiration and you will see presence of an anchovy sauce. Okay. So pair is not done. Pair is done for hydrated cyst. PAIR stands for percutaneous aspiration, reinstallation of scolicide agent, installation of scolicide agent and reaspiration. Okay. Medical management is correct. I would like to go with high dose metronidazole. He's asking for next step in the management. Surgical is not, reassurance is not. Answer is B for Bombay. Absolutely correct, right? So with this, we conclude our PYQ series in your surgery, right? Remember, all these questions have been asked in your exams previously also. So we have tried to analyze them, put them in one single context so that you'll be able to understand it better. I will be sharing this entire PDF or entire PPT on our Instagram channel or as well as on our Telegram channel as well. So stay focused. The exam is not far. Right now, your objective has to revise, not to read. Whatever you have read is enough. You have to revise whatever you have read before. Revise, revise, revise. Do GTs. Give your PYQs a better shot. Always analyze your mistakes and try to work towards it. Close, put everything towards a focus. Cut the noise out. You don't need to listen to anything else. Be focused. And once the exam is done, trust me, if you have followed it well, the life is going to be super, super easy and super, super cool. So with that, thank you guys. Have a good time. If you have any questions, you can reach out to me to my personal Instagram channel. That is going to be the surgery guy. You can look it on my name also, Dr. Sandeep Seeram Reddy. Any question, any time of the day, night, wherever you can post it on the Instagram or on, you can directly DM or you can put it on my Telegram group also. I will try to answer then and there itself for you. With that, signing off. Thank you so much. All right, guys, take care. Bye.